Everyone can see the slide. Dr. Alimi, you can see the slide?
Yes, we can see your slides.
Okay. So good evening, everyone. My name is Farha Pacha, and today we're going to be talking about congenital heart defects. So that's today's lecture. So starting with cyanotic, we're going to start with cyanotic heart defects, then acyanotic, and we're going to explain the difference between them, and then we're going to proceed with the individual defects. So just give me a second, please. I'm going to mute my phone. Yeah. So cyanosis, the meaning of cyanosis is actually a bluish color in the skin, lips, nail beds, which is caused by a decreased level of oxygen in the blood. And cyanosis, it usually occurs because blood with low levels of oxygen, they turn the skin blue and purple. And this low oxygen blood causes a purple or a blue tint to the skin. And cyanotic heart defects basically means that there's a right to left shunt, and it leads to early cyanosis, which I again mentioned. It produces blue babies. And usually it's diagnosed prenatally, and it becomes evident immediately after birth. And there are 5 different defects that are associated with cyanotic heart defects. Just the question, is the lecture being recorded, or should I?
The lecture is being recorded. You can proceed.
Okay. So there's 5 defects that are associated with this a cyanotic heart defect. It's a truncus arteriosus, transposition of great arteries, tricuspid atresia, tetralogy of Fallot, and TAPVR. So we're going to discuss each one of them in more detail in the upcoming slides. So cyanotic mana che kala vena, the right garina, the right side of the lung, the heart, and the left side of the heart tashan kigi, او هغه چې دا deoxygenated blood ورته راځي او دا د دې سبب ګرځي چې ماشومان usually هغوی شین رنگ ست پروډوس کې خپل په سکن کې خپل په lips کې خپل په nails کې and in general like toes and fingers as well. So acyanotic heart defect, this is when there is a so the defect is from left to the right shunting, and this may be relatively asymptomatic at birth, but it can lead to later cyanosis after the shunt reversal. So with shunt reversal, we means that initially for acyanotic heart defect, vena چې دا the left side the heart نه right side heart ته ځي او هغه later cyanosis cause کوي مطلب cyanosis په later ژوند کې cause کوي ځکه چې او هغه only په هغه حالت کې کله چې shunt reversal شي. Shunt reversal یو concept د Eisenmenger syndrome ده چې موږ upcoming slide کې تاسو discuss کوو, and these babies are usually not blue. They produce, as I mentioned, blue babies in later stages of life. They include ventricular septal defect, atrial septal defect, and patent ductus arteriosus. And out of all of these, ventricular septal defect, this is the most common one. So if we discuss the difference between cyanotic and acyanotic. So cyanotic means that there's a less blood, normal oxygen level. There's a less oxygen level in the blood that's being delivered to the body. So, and this is associated with a right to left shunt. So this is associated with blood that moves from the right side of the heart, because usually the right side of the heart, it contains deoxygenated blood. So when the blood moves to this side, to the left side, we refer to this as cyanotic, because the deoxygenated blood, it gets mixed with the oxygenated blood on this side. And acyanotic means this is which oxygen levels that are delivered to the body, they remain normal, and this is left to right shunt. So this is basically normally left ventricle, obviously they contain oxygenated blood. So when they shunt over to the right side, the oxygenated blood comes to the right side, and usually this blood from here then goes into the lungs. So it does not create any huge difference unless there's a shunt reversal, which we're going to discuss in the later slides. So ventricular septal defects. So this is basically, it's a defect between the right and the left ventricle. So when the blood enters the right ventricle from the right atrium, it will continue to flow through the pulmonary arteries into the lung, like a normal, how it happens in normal blood circulation. And instead of entering the left ventricle through the defect. And this is because of the pressure difference between the right side and the left side of the heart. So there's a higher pressure on the left side and there's a low pressure on the right side of the heart, because the right side of the heart, it pumps through a low pressure system, which is the pulmonary circuit, whereas the left side, it pumps blood to a higher pressure system, which is the systemic circulation. So, however, the blood then entering the left ventricle from the left atrium is able to cross over these defects. So, if you can see, there's this defect that comes from the right side to the left side. Someone's mic is not unmute. It comes from the right side to the left side. So yeah, basically, with ventricular septal defect, this is when it enters from the left ventricle to the and it crosses over to the defect onto the right side, and this basically results in left to right shunt. So if this VSD is small, it's usually asymptomatic, but if the defect is usually large, then it means that there's a large volume of blood that will cross over to the right side. And it's actually this increase in blood volume in the pulmonary circuit that actually leads to pulmonary hypertension. So there's a high blood pressure in the pulmonary circuit. So basically, with this defect, what happens is that there's a whole opening. So the defect is the opening, the right ventricle and the left ventricle means opening or the ventricular septal defect way. No, because the right left the higher pressure system or right the lower pressure system matlab low pressure or right or left high pressure no zaka vina amisha the high pressure through low pressure system تزي so data خاطر ممكن left to right shunt way or chunda oxygenated blood contain كي no the deoxygenated غادي تزي no this is why the acyanotic the मतलब the blue babies na produce كي and over time over time when the blood volume increases onto the right side, it eventually results in a pulmonary hypertension. So there's a high pressure in the pulmonary circuit, there's a congestion of the pulmonary vessels, and this basically results in increased right-sided pressure, so increased pressure of the right side of the heart as well. And because there's increased pressure on the right side of the heart, this will basically the pressure of the right side of the heart will increase. It will be more compared to left side. So the pressure on the left side will be little in comparison to the right side, and this will basically result in a shunt reversal. Shunt reversal means that now the blood will move from the right side to the left side. And this concept is known as the Eisenmenger syndrome, basically. So, Kalachi was initially vina the left na right tarazi, but over time, kadal the pulmonary over time, the fluid overload ki paride ki pulmonary hypertension cause ki, or the sabab the girzi chadal the pressure per the right ki diri nasbat the left garina, or the wajina the shunt chida zan reverse ki matlab the right na left tazi initially mugul chida the left na right tazi os the right na left tazi or kalacha pressure the right in the left talaro no matlab it's not working kalacha the right na left talaro matlab it's cyanotic, it produces cyanosis because it goes deoxygenated bloods move to the to the left side, and then the blood from here is then being pumped to the rest of the body. And this concept is known as the Eisenmenger syndrome. So usually, and these kids, usually, obviously, it involves like surgical treatment is needed for closure of this defect, or it may just close spontaneously as well. So if we can explain it in better words, yeah. So this is the aorta, and this is the pulmonary arteries. And because we said Eisenmenger syndrome, initially the shunt is actually from the left to the right. So the shunt is like, this is the defect. So the shunt is from the left side to the right side. But over time, when the blood volume over here increases and there's a pulmonary hypertension over this side, what happens? This leads to shunt reversal. Shunt chida birtazan di gari tabadle zaka chidal the pressure dirigi. No da data be mongoi che right to left shunt. And di gari ta chida deoxygenated blood da delta oxygenated blood da. Or chun deoxygenated blood oxygenated area tarazi, which means that it gets mixed with this with the blood on this side, and then it's being pumped to the rest of the body through the aorta, and that's why it produces cyanosis, because it's not it does not contain a high level of oxygen. So this is did you guys get the concept of this? Okay.
Yes.
All right. So let me just. So now this is Eisenmenger syndrome chimunga uela. Usually Eisenmenger syndrome chidakan aga I cyanotic heart defects kipeda kigi kalachi shunt reversal shi. So usually munga chi mention ka a cyanotic agada kalachi left garina right garita ze. Lekin chun pressure be amdaga se over time chun fluid overload kigi parai gare ke awaga increase pulmonary blood flow cause kei, and eventually injury of endothelial vessel cause kei in the pulmonary vessels, and eventually it leads to increased pulmonary vascular resistance. There's increased congestion in the pulmonary vessels, and eventually chida right to left shunt cause kei matlab the wajna because the pressure dirigi pa khigara ke no zaka shunt chida the khigari na chap gari tazi or the tamung Eisenmenger syndrome way. So you can see that there's a left to right shunt. So long-standing left to right shunt leads to pulmonary hypertension, and over time this results in cyanotic right to left shunt basically. Okay, so now moving on to the atrial septal defect. And atrial septal defect, this describes a condition where the septum between the right side and the left side, they do not close up all the way and they remain open even after birth. So there's basically normally this is how the septum is supposed to be in a normal individual. It's supposed to be closed, but when a baby is during fetal development, they have this is open, and that's normal. But when the baby is born, it's supposed to close. But septal defect means that this opening remains even after birth. So this means that there's now this opening in the septum. So now, how there's a high pressure in the left side of the heart and on the right side, and again, as we talked about it in the ventricular septal defect, how this pressure difference again causes the blood to be shunted from the left to the right side. So again, as you can see, the blood is moving from left to the right side, and again this means that more oxygenated blood gets over to the right side, which is usually a deoxygenated blood system, and this type of defect is acyanotic again because it does not affect the rest of the body. Like it does not there's no low level of oxygen, it's not being pumped to the rest of the body. And this is basically associated with a complication known as the paradoxical emboli. So if you can see in this defect, so basically this is when there's a hole between the right and the left side of the atrium. And the ventricular septal defect, there was a defect here, there was an opening here, but here it's opening in between the atria. So again, this means the blood is being moved from the left to right, and it's associated with acyanosis because it does not affect the oxygen saturation or oxygen level that goes into that's being pumped to the rest of the body. And this is usually associated with paradoxical emboli. So what is paradoxical emboli? So usually you see that a person that has a deep vein thrombosis, like a DVT. So what happens is that part of that blood clot, it usually breaks looses, and then it forms an embolism. And that embolism usually travels to the right atrium and then the right ventricle, and then usually it's pumped to the lungs, which results in the pulmonary embolism. But this is the normal cause of how like pulmonary embolism is basically caused. That's how it leads to pulmonary embolism. However, because we have an opening here, like there's an opening here, because of this opening, it's possible that this embolism that comes, by the venous return, this crosses over to the left side, in which case it means that it enters the systemic circulation because it enters the left side of the heart, and it then potentially can lodge into the brain and cause stroke, because when the embolism enters the left side, left atrium, what happens is that it can go through the aorta and then eventually can actually lodge into the carotid arteries. And what happens is that this situation is known as paradoxical embolism. That's because we say that the embolism starts off in the right side and then it crosses over onto the left side. So basically, paradoxical embolism chida غير complication that this غير complication that the atrial septal defect او मतलब normal DVT की चदा आगे के normal blood clot चिकला breaky की DVT ना आगे embolus form कीगी आगे example right atrium ta flow कीगी वम दगस right atrium ta right ventricle तराजी दगस आगे pulmonary artery ta lungs तजी as a result आगा pulmonary embolism cause की लेकिन पदगा situation की चलते चमूंग सरा atrial septal defect ये दगल पदगा opening protein दगा opening दवजना कल चदा embolism राजी दा दगल तजी दगा opening दवजना दा left atrium तजी so मतलब यानी दा systemic circulation the entrance पैदा की दगा से दा left ventricle तजी दगा से दा aorta तजी and eventually the brain तबतलेशी brain तचकल लाशी आगा सबब the stroke गर्जी ischemia गर्जी so दे दखातर मुंगा paradoxical embolism way. With this, the atrial septal defect, so as we said, it's a division between the right, there's a hole between the right and the left atrium, and the most common type is ostium secundum. So in 90% of the cases, so ostium secundum, this is the matlab yani the hole to the opening to the center ki prutta, and ostium primum is basically least common type, and it basically occurs in 25% of patients, and this is basically when the defect is located lower in the lower portion of the atrium. So ostium primum matlab da dwa raqam so openings they're common da, and ostium primum is less common da 25% of khalko kida or da chida da matlab lower portion the atrium kida da pisab like land atrium ki da defect fruit there. So, and here you can see the picture. It shows intraoperative view of multiple pinhole atrial septal defects. Delta like multiple daga holes goril, the multiple atrial defects, like here, like here, like here, and it's a real human heart picture. Pause. So, patent ductus arteriosus. It is the third type of acyanotic heart defect. And with this one, so what happens is that the ductus arteriosus, which is this one here, this is a physiological blood vessel that connects the pulmonary artery to the aortic arch, as you can see the connection. And this basically allows blood from the right ventricle to bypass the non-functioning lungs and a normal fetal development. And once the infant is born, the ductus arteriosus, what it does is that it closes and it becomes ligamentum arteriosum. And failure of this blood vessel to close, that's what results in patent ductus arteriosus. So daga shiryan chita suguri that ductus arteriosus da normally that the physiological blood vessel da chikala your fetus aqbal dumur provum ki developmental stages ki no da essential da chidalta daga da ductus arteriosus izakachi kalachi vena zamu right ventricle tarazi aga vena satazi aorta tazi and daga descending aorta tazi to get oxygenated like in the plasma in the placenta, and this has been the concept of the munga fetal circulation kiwelo. So if you are confused about how this normal fetal circulation works, then you can just read over that PowerPoint presentation or listen to the lecture and you will understand it. But usually, so that normal physiological da, but kalach mashum pedashi da asal ke ligamentum arteriosum tabadligi. So matlab da zan da vessel zan close kai da zan urke kai or da bande zan da ligamentum arteriosus tabdiligi. Lekin kalach bad pedaish na kada charta ligamentum arteriosum tabdil nusho no of dam da qas ila patishu no data munga patent ductus arteriosus way. So you can see this is the ligamentum arteriosus. This is how it's supposed to be when the baby is born. But if it's not turned into this and it remains open, that's when it's called patent ductus arteriosus. And so you can see that here the blood is basically comes into the right atrium and then goes into the right ventricle again, and it approaches this ductus arteriosus at this point. And now it has two options. So it can either go into through the pulmonary artery into the lungs, or it can go into the aorta. But because, which is a higher pressure system in the aorta, but since the blood likes to move from the higher pressure system to a low pressure system, and because there's a high pressure in the aorta, therefore, this blood that comes from the right ventricle into the pulmonary artery, it continues to flow into the lungs. So next, what happens is that when you have freshly oxygenated blood coming over into the left atrium, the left ventricle, and then it goes into the aorta. And this time, the blood is already now in a higher pressure system. And now some of it can be shunted back to the lower pressure system in the pulmonary artery. And at this point, it is known as the left to right shunt, because oxygenated blood flows back and takes a second trip to the lungs. So basically, Kalachivin example, the right atrium, the right ventricle, tarazium, dagasi, the pulmonary artery, through pulmonary artery, da delta dua optional is chunos delta zmunga opening the vessel da kana da defect that was two routes like ya khuda lungs talarshi ya khuda aorta talarshi, but chun delta pressure chida kamda or munga early discuss oka chipa left side chida aga your higher pressure system da. So aorta your higher pressure system da, so da nishi kawala chida vina these in a delta diselarshi. So this is why da vina amda se lung to continue kigi. And then kalach also like blood the through pulmonary veins, left atrium tarazi, and then left ventricle tarazi, the oxygenated blood. Us vena chida blood is the higher pressure system kida. Matlab aorta ki blood the higher pressure system kida. No us mumkin da chida gazina vena blood us delta flow shi. Like it can come back to this side because now the blood is moving from a high pressure to low pressure due to this pressure difference. So it's possible for the blood to flow from the aorta to the pulmonary artery. And this is known as the left to right shunt. This is still left to right shunt because this is it goes from the blood is moving from the left side to the right side, and that's why it's again acyanotic, because it does not affect the oxygen level in the body at this stage. So usually this is basically asymptomatic, and patient can have what is known as the holosystolic machine-like murmur from the blood moving from the aorta to the pulmonary artery. So this basically produces a holosystolic machine-like murmur. When the blood moves from the aorta to the pulmonary artery, it produces this murmur. And what happens is that later on, because as the blood keeps flowing to the pulmonary artery, the patient develops pulmonary hypertension from like years of increased pulmonary blood flow, increased high pressure on the pulmonary side. And if this happens, the pressure might eventually increase. So it's basically the same concept as we explained in the previous slides, that the pressure might eventually increase to a point where the right-sided pressures are greater now than the left-sided pressure, and this flow of blood through the PDA will then lead to reversal of shunt. Again, the concept of Eisenmenger comes here. So this means that blood will now cross over to the aorta, so changing from the left to right shunt to right to left shunt. And again, this is the Eisenmenger syndrome. So what happens is that when the blood over time to the delta blood over time as time passes delta pulmonary hypertension poski because delta due to fluid overload and our pulmonary hypertension to the aga delta right sided heart to the ari pressure amzan sare chikai uchet kai increase kai او aga again delta mungta shunt reversal ra kai again os delta chun the right sided ventricle pressure to the be the left side in the dairy أو chikala left sided nadiri that pressure. No, somebody's drawing. Okay. So when the collective pressure, the right-sided pressure, the left-sided nadiri, no aga shunt reversal key again. Matlab aga right-sided na left side, aga right to left shunt kigi. أو college right to left shunt وشي مطلب أغا deoxygenated blood لخي غاري تزي أو أغا access لريش أغا ستلارشي زمون rest of the body تلارشي. So now explaining the concept of Eisenmenger syndrome in this concept. So when you get deoxygenated blood flowing into the aorta, so when there's now a right to left shunt, now you get deoxygenated blood coming from the right side and it flows into the aorta. And generally, it actually affects the lower extremities. And this results in cyanosis of the lower extremities. And this situation is known as the differential cyanosis because only the lower body is cyanotic because the upper extremities and the head, they usually have arterial branches that are upstream from the PDA. So, okay. This is a very simple illustration. So if we explain the Eisenmenger syndrome and patent ductus arteriosus. So this is the PDA. This is the aorta, and this is the pulmonary artery. So usually we said that there's a high pressure on the right side, and that's why the blood will move through this defect into here. And over time, chida delta pressure ziyatigi because volume overload ziyatigi, right sided pressure diri. No aga sabab de Eisenmenger syndrome girzi matlab aga shunt reverse ke shunt yani aga us dena ch blood delta larshi blood us chida the gadi tazi. The khina chabgari tazi through this place here. أو data today data generally today deoxygenated blood today aga lower extremities tazi the dagwana kala Eisenmenger syndrome ki deoxygenated blood today aga lower extremities tazi aga upper extremities his na affect kai matlab yani aga zamung lasuna arms or zamung head aga na affect kai or dagi wajada da zakache da branches gore da the arteries da chida da zumunga da blood upper extremities ta pump kai da and or da PDA chida da like land the prute the dagi branches na no zaka the upper extremities are unaffected zaka chida PDA like land the prute no bina chida da gazina deoxygenation shuru kai da gaze his na affect kai. So this is the concept of that. And usually when the defect is small, it's usually asymptomatic. When it's large, it's likely to cause dyspnea. And causes normally appear to be rubella, which is like a viral infection in the mother. You can also have perinatal distress hypoxia as well in the fetus. And treatment in patent ductus arteriosus is usually neonates. It's actually prostaglandin inhibitors, which is used to close the PDA. And prostaglandin itself, it's during fetal development, it's produced by the ductus arteriosus and the placenta to keep the ductus arteriosus open. However, at birth, what happens is that when the oxygen level increases, goes up, the prostaglandin level falls, and as a result, it causes the ductus arteriosus to close off. And and symptomatic and large PDAs, they actually require surgery. So in terms of treatment, with the prostaglandin inhibitors work. Normally prostaglandin aga placenta or the ductus arteriosus, fetal development produce kai. Lekin kalachi ماشوم پیدا شي د پروستاګلاندین لیول کمیږي او اکسیجن چې کله ډیریږي نو هغه څه کوي هغه دغه ډاکټس ارټریوسس کلوز کوي لیکن کله چې ماشوم ډیولپمنټل سټیج کې خپل د مور په ووم کې نو پروستاګلاندین رول دا ده چې هغه د ډاکټس ارټریوسس اوپن پریږدي سو د خاطر چې کله انفانت پیدا شي هغه ورته انهبیټرز د پروستاګلاندین ورکوي چې دا پی ډي ای کلوز کی And now دغه پورې مونږ دا a cyanotic heart defect so اوس دغه زینه and forward from here دغه زینه this is gonna be sorry the above slides there were acyanotic heart defects but the upcoming slides they're going to be cyanotic heart defects so we're going to start talking about cyanotic heart defects in here so tetralogy of Fallot is
Dr. Parha,
one of the
please clear your screen هر چا چې لیکل کړي په سکرین باندې خواهش هم دا ده چې خپل هغه سکرین چې چا لیکلی د هغه پاک کړي او تاسې هم آپشن لرئ دلته چې کلیر د سکرین هلته خپله دا ټول کلیر کېږي بلکې تاسې مهرباني وکړئ انوټیشن د نورو لپاره بند کړئ یوازې د ځان لپاره اون کړئ نو دا به نه وي تاسو ته
I think ما خپل ځان لپاره اون کړ
نه ایموج لپاره هم اون دی اوس صحیح شو اوکې
okay my fault
okay proceed please proceed
okay. So let me just so tetralogy of Fallot this is again it's the most common cause of cyanotic congenital heart defect څنګه چې موږ وویل په cyanotic کې چې دا ventricular septal defect most common cause دا او په cyanotic کې چې دا ventricular septal defect most common cause دا په cyanotic کې چې دا tetralogy of Fallot most common cause دا او usually په tetralogy of Fallot کې چې دا the atrioventricular septum چې ګوري هغه like right غاړې ته shift کیږي so normally atrioventricular septum is here but in tetralogy of Fallot what happens is that this septum is shifted a little bit to the right side so instead of the septum okay let's just annotate it here somewhere okay so draw. So normally, this is here's the atrioventricular septum, but in tetralogy of Fallot, what happens is that this atrioventricular septum is moved a bit here onto this side, onto the right side, and as a result of this, it's a consequence of this. It results into in 4 different defects, at least 4 different defects. So atrioventricular septum چې دا اصل کې دغلته پروت ده but په دغه ډیزیز کې دغه ډیفیکټ کې چې دا هغه لک خي غاړې ته راغلی ده لک خي غاړې ته پروت ده او چې دغه د وجه نه دا سلور different defects کوز کوي یعنی دا سبب ګرځي چې سلور different defects دلته پیدا شي because of only this little this movement only so the first abnormality is as you have mentioned it's a combination of 4 different heart defects which usually occurs when there is a shift of the atrioventricular septum slightly to the right side. And the first abnormality is stenosis, or you can say the narrowing of the right ventricular outflow tract into the pulmonary arteries. You can see there's a stenosis, and this could be either narrowing of the valve itself or narrowing of the infundibulum, which is the area right below the valve. But either way, it makes it harder for the deoxygenated blood to get into the pulmonary circulation because there's a stenosis here, and that's one of the first defects. And in response to this narrowing of pulmonary valve, what happens is that the myocardium, the right side of the myocardium, this area here, this is the stenosis, this is the normal heart. I was pointing here. So the myocardium, which is the of the right ventricle, it undergoes hypertrophy, or you can say becomes thicker. So hypertrophy means that there's that the cell itself it grows, it increases due to mechanical demand. So and this gets thicker and it undergoes hypertrophy in order for it to contract harder and push the blood past the stenosis. So this is the second feature. So basically, tetralogy of Fallot ki awal feature the awal defect aga narrowing of the narrowing of pulmonary valve the pulmonary artery valve this is the stenosis of the and in response to this the right side of the heart the zan ghat kai matlab the cardiac myocyte zan ghat kai yani aga zan double aga hypertrophy undergo كي شغا أوكا ولا شيء دلتا contraction دلتا their contraction worky force delta increase key, so the blood can flow through this stenosis. Basically in response to the stenosis, this is why you get like a thicker right ventricle in order for it to contract harder and push the blood through this stenosis. So this is the second feature. And the third feature is basically VSD, so ventricular septal defect. And VSD, this basically allows the deoxygenated blood to flow from the right ventricle and to mix with the oxygenated blood from the left ventricle. So we also mentioned that the VSD, it occurs in isolation as well on its own, and that it was part of the cyanotic heart defect. But the غلطة pathology of Fallot, you can also find VSD, which is here, like there's an opening between the right and the left ventricle. So what happens is that So in this case, the oxygenated blood is shunted from the left side to the right side because the pressure on the left side is higher than the pressure on the right side. That's in the case of a normal when VSD occurs in isolation. But for patients who have a tautology of Fallot, because the pulmonary stenosis causes the right-sided outflow obstruction, so causes the obstruction at this point, the blood is then being pushed towards the left side, and hence it causes a right to left shunt, and it is seen and it's this right to left shunt that leads to cyanosis, and it's the degree of the stenosis or narrowing that actually decides to what extent the shunting and the cyanosis should occur. So in isolation, what happens is that there is when there's a cyanotic heart defect and you have ventricular septal defect, it is from right to from the left to right side. That's where the shunt is. But in case in terms of VSD, shunting the right side na left side the matlab deoxygenated blood us left side the flow ki. And this is because of the cyanosis. This is because the pressure data the stenosis and the hypertrophy the heart this pushes the blood to go to the left side, sorry. And then the fourth defect it's known as the overriding aorta. So this is when the aorta, this actually sits above the ventricular septal defect, and it's giving a biventricular access, meaning that it takes blood from both ventricles. So aorta padara defect like above the VSD prota or this has basic access like the aorta vina the right the left and that's why we say has a biventricular access. And causes is usually alcohol drinking, especially pregnant women. It can be poor nutrition. It can be like viral illness, as we mentioned, like rubella. Down syndrome, children has it too, and Down syndrome, which is a chromosomal disorder, abnormality. I think it's abnormality in chromosome 21. And let's move on to the next slide. It's able to move. Everyone can see the slide. Dr. Alimi's slide is visible?
Yes, please.
Okay. So in terms of symptoms, what happens is that the children, they develop TET spell, which is like sudden decrease in oxygen saturation, and this is characterized by a harsh holosystolic murmur at the left upper sternal border. So usually the children, they have low oxygen in the blood, and this makes their lips, their fingers and toes to appear more cyanotic. So what patients do is that they learn to squat. So they sit in this position here, and this is basically a compensatory mechanism that increases the vascular resistance, and it decreases the right to left shunt, and therefore increases the pulmonary blood flow. So that this means more blood can flow into the pulmonary arteries and more blood can get oxygenated. So this is why they have this, they sit in this position. And boot-shaped heart on X-ray, this is when we saw that this is basically due to right ventricle undergoing hypertrophy. So when the right ventricle undergoes hypertrophy, it's shown as a boot-shaped on an X-ray machine. So transposition. So usually, again, treatment with the in case of tetralogy of Fallot is again prostaglandin analogs, and that's basically to keep the ductus arteriosus open to improve the cyanosis until surgery can be done. So basically tetralogy of Fallot kichida ari ke in terms of treatment chida what the prostaglandin analogs were kich aga ductus arteriosus ila pregdi or cyanosis improve kitar such surgery ta child prepare she. And we also already mentioned prostaglandin the dagri rule and that ductus arteriosus open key, as we said during the patent ductus arteriosus. We discussed that. And then this is a second type of cyanotic heart defect. So this is a transposition of great vessels. And here, what happens is that it basically means that the aorta, it usually arises from the right ventricle, as you can see, and pulmonary artery, it arises from the left ventricle, as you can see, and that's due to failure of the aortopulmonary septum to spiral. So the deoxygenated blood from the body, it returns to the right atrium and then it's pumped back to the body via the aorta, whereas the oxygenated blood from the lung is being continuously pumped back into the lungs by pulmonary artery, without it ever going to the body. And this basically creates two separate circulatory systems, so two distinctive, or you can say two parallel circuits, instead of a normal circulatory system which runs in a series. And so basically that's aorta, normally aorta chida zimung left ventricle ta attach the pulmonary artery chida zimung right ventricle ta attach the, but padaga case ke aorta zimung right ventricle ta attach kigi and pulmonary artery left ventricle ta attach kigi. Or kala chi venous return razi deoxygenated vena chakala razi blood razi aga, instead of going to pulmonary artery aga zimu aorta tazi, or aga pump kigi rest of the body ta through the aorta daga deoxygenated blood. Lekin kala chose oxygenated blood left atrium na left ventricle tarazi pulmonary artery tarazi. So daga ke vena chida, it's continuously it's oxygenated and continuously goes into the lungs and comes back. So it does not, there's no way for the heart to go, for the oxygenated blood to go to the rest of the body. So basically, in this case, what happens when the fetus is still in the mother's womb, the babies with this defect, they don't have any symptoms because they're not using their lungs yet. Instead, they rely on blood from the mother and few shunts for blood flow, such as like foramen ovale, which is like basically gap between the atria, the ductus arteriosus, which we discussed. And however, in this parallel circuit, this is usually incompatible with life, meaning that it can lead to death unless there's a communication and there's a mixing of blood between the two parallel circulations. So it's only possible of this happening if the foramen ovale or ductus arteriosus stay open, or if the baby has a ventricular septal defect, which allows which allows the blood to mix from the right, between the right and left side. And usually in these children with this defect, in 1/3 of such kids have ventricular septal defect, which basically allows the blood to move between both sides of the heart. And so basically any of these possibilities can actually allow this independent circulation to mix blood and deliver some oxygen to the tissues. So normally chida kala chi mashum khpal more vumki again da dumragat ishuni زکه چې هغه ماشوم خپل د مور نه اکسیجن اخلي، لیکن کله چې ماشوم پیدا شي که دغه سي ډیفیکټ ولري کنو هغه ماشوم زیاته ژوند نشي کولای، هغه انکمپاتبل لایف سره، سو هغه ژوند نشي پاتې کېدلی. لیکن اونلی په یو ممکن د هغه ژوندې پاتې کېدلو په دغه حالت کې ده کله چې دلته زموږ کوم ډیفیکټ یا دلته کوم اوپننګ وي، لکه اگزامپل که دلته زموږ ductus arteriosus open، که دلته موږ atrial septal defect ولرو، که دلته موږ ventricular septal defect ولرو. only په دغه حالتونو کې چې دي هغه ماشوم can be compatible with life ځکه چې then the body can receive some oxygen ځکه چې هغه defect shunt create کوي او دغه shunt د لارې نه وینه چې دا oxygenated and deoxygenated وینه چې دغه mix کیږي so the child is able to live. So this is basically again a very simple diagram to explain this. How we said that, you know, and this is a normal circulation. How we said that the circulation in a normal individual, in the circulatory system is in series. So you get blood from the right atrium, the right ventricle, and then pulmonary artery, and then lungs, and then comes again through left atrium, left ventricle, and then aorta, and then to the rest of the body. But in this case, what happens is that the blood is being there are two parallel separate circuits. So you get only if blood is coming from the right atrium, right ventricle, then aorta. And there's no connection between these two circuits and then back into the body. And this is basically the blue color basically means there's a decreased oxygen. So there's a low level of oxygen on this side. Whereas on this side, it's oxygenated because it's the left side. But and that's where the blood is being continuously pumped to the lungs and then again back and forth. So the cycle continues. And you can see that the aorta, normally aorta by dagalta pruti and pulmonary artery by dagalta pruti, but the place has been swapped because of the defect. So what happens is that because the right ventricles now they pump out to a high pressure system circuit, even though it's built for a low pressure circuit, and the left ventricles they pump out to a low pressure pulmonary circuit, even though they're built for a high pressure system. So in response to this, what happens is that the right ventricle, it undergoes hypertrophy or gets larger, and the left ventricle, it might undergo atrophy and get smaller. And these changes in heart structure can ultimately, over time allow the heart to fail. So usually the right-sided heart build up شوی دا in a for low pressure system دا ځکه چې دا خالي normally چې دا خالي زموږ lungs ته سور کوي blood pump کوي, whereas the left side of the heart چې دا higher pressure system دا because دا زموږ ټول وجود ته blood ورکوي. But په دغه case کې because of this defect this right side, because now it's padach also vina chida the tool system to work the right side heart responsible that you the blood tool system to pump through the aorta agam deoxygenated blood no over time the right side the hyzana gatkai the hypertrophy the undergo the hypertrophy undergo whereas the left ventricle the atrophy undergo da zan work because although the it's for high pressure system, but because of this it pumps blood to a low pressure system. That's why it undergoes atrophy. And as we also mentioned, da mashum aga halat ki compatibly kala chi dalta munga solaru dalta munga ya ventricular septal defect dagalta laru ya atrial septal defect laru ya dagalta PDA dagalta pruti no pada halat ki aga mashum be compatibly life sara zaka chi aga blood allow kai chi both sides dalarshi. And also, less commonly, babies can also have levotransposition, so of great arteries. And this basically means that aorta is actually, it is primarily to the left side of the pulmonary arteries. So in this form, the great arteries are still connected to the wrong ventricles, but the ventricles have switched places along with their atrioventricular valves. So in this case, unlike the transposition of the great arteries, the circulation is preserved in the in levotransposition, and that it's because it's acyanotic, it's not blue, and for this reason, babies with levo transposition of the great arteries, they usually won't have any obvious symptoms. So for levo transposition of great arteries to the diable type the transposition of great arteries awagi ki chida khali ventricles zan ze badal kare de delta ventricles chidi kana yani left ventricle left ventricle khigadi taragale da and then right ventricle chab غاړي ته راغلی ده او دغه ته مونږ levotransposition وایي لیکن aorta او pulmonary چې دي هغوی خپل ځای نه دی بدل کړی په levotransposition کې او دا دومره rare ده او دا less common ده او دا چې دا acyanotic ده compared to this one. So gonna move on to the next slide. Again, the treatment for this is again like prostaglandin, but that's a short-term treatment to keep the ductus arteriosus open, to allow the mixing of blood in the two circulations, before surgery is done. So, again, prostaglandin mashim tawarkol kigi che your short-term solution that ductus arteriosus open prigdi kadal the besab the ductus arteriosus open prigdi, or so the blood can mix basically. And then persistent truncus arteriosus. This is also very rare type of cyanotic heart defects. And this is basically, so truncus arteriosus, what it is it's basically a big structure, and it's present during fetal development, and latent development divides to form two separate arteries, the aorta and the pulmonary artery. So this basically a persistent truncus arteriosus, it describes when this developmental structure that you can see, this does not divide into separate arteries. So instead the baby is then left with one giant trunk, one giant artery, and it also has a ventricular septal defect and allows oxygenating deoxygenated blood to mix at this point before it's ejected through this trunk through this common valve of this trunk, to a great single artery. And then later on at this point, the blood is being this trunk is being then splitted off into aorta, into pulmonary artery. So when deoxygenated blood mixes into the systemic circulation, it's often present as cyanosis. So again, cyanosis is a bluish purple discoloration of the skin, and it can be seen baby within the first few days after birth. And usually so the truncus arteriosus the normal structure that during developmental stage, or the asal kitchen during development of fetus, the aorta and pulmonary artery the divide kigi, but sometimes it defect matlab da na divide kigi dalta, or the your common trunky common artery the persistent truncus arteriosus ke ventricular septal defect ham proti matlab the so the advantage that the blood the left side and the right side, na mix kai, and then the blood through the main arteries, through main the yo valve like normally aorta da aga left غاړه کې da and pulmonary artery right غاړه کې da او غوډ خپل separate valves لري because they've been separated, but in this context it's only one common valve, and دغه روسته da be split کیږي into pulmonary artery and into the aorta. Da دومره common نه ده, so دغه دومره detail لا نړم compared to the previous slides. And then you have also got tricuspid atresia, and in tricuspid atresia, there's basically a complete absence of the tricuspid valve, as you can see, and this basically means there's no connection between the right atrium and the ventricle. So what happens is, because there's like complete blockage, there's absence of the valve. So what happens is that the right ventricle is like hyperplastic. Hyperplastic basically means that there's an incomplete development, or you can say underdevelopment of an organ or tissue. And this basically, in this case, there's no way for the venous blood to get oxygenated into the lungs because the pathway has been closed. And therefore, for this infant to be compatible again with life, the ASD or VSD must be present in this condition, because ASD will allow the blood to be pumped into the left side, while VSD will allow the blood to travel to the pulmonary arteries to get oxygenated. So, the condition tricuspid atresia daga matlab the tricuspid valve da bihi absent da. Normally right atrium and right ventricle means give valve protein, allowing the blood to flow, but in this case there's absence of this valve, and therefore as a result there's no blood that can flow, there's no venous return that can flow into the right ventricle and get oxygenated into the by the lungs through the pulmonary artery. No, په دغه defect کې د ځان right ventricle ځان ورکې کوي in response د ځکه چې د وینه نه رسیږي او دغه کدلته په دغه defect کې دغه VSD باندې ني presence ني او دا ASD present ني نو دام کدلته present ني نو دا ماشوم په uncompatible یعنی دا ماشوم ژوند نشي کولای. That's why, so for this mushroom to be compatible with life to jonduki, no agid khatara da VSD bite delta mawjudi or delta age receptor defect bite mawjudi. So like your opening bite mawjudi chu the agid zarina blood mix shi or the agid zarina blood lashi lungs da yeah oxygenated shi, so the body receives some oxygenated blood. Again, this is also very rare type of cyanotic heart defect. And then there's a total anomalous of venous return. So in this case, this is when the pulmonary veins, as you can see, the pulmonary veins, they normally return oxygenated blood from the lungs to the left atrium. That's what their role is. And eventually to the systemic circulation. But in this condition, in this defect, the pulmonary veins, they're connected with the right side of the heart. So they're either connected to the right atrium, superior vena cava, depending on the type. And this basically leads to a closed circuit of venous blood flow. So oxygenated blood leaving the pulmonary vein does not flow to the left side of the heart. And for it to be compatible with life, again, ASD and PDA needs to be present. So normally, chida zumunga pulmonary dike pulmonary veins shida the right side of the heart connect the normally pulmonary veins role chishida oxygenated blood rauri zumunga left ventricle left atrium tarauri left ventricle tarauri, you know, and basically bring oxygenated blood to the left side awaga be pump she like through the aorta to the rest of the body. Like in padaga defect ke the hiscum connect the pulmonary veins shidi hiscum connection nalari left side of the heart the khali right side of the heart the connect the. So oxygenated blood to the right side of the heart through the anomalous vein. And then there are three different types. So supracardiac matlab the pulmonary veins the red, this is the pulmonary vein. It opens into the superior vena cava by abnormal anomalous connecting vein. So it opens into the superior vena cava by this connecting vein. And infracardiac, this is when you can have again this pulmonary veins, they open into the portal or hepatic veins or inferior vena cava in this case too. And intracardiac, this is basically when it opens into the coronary sinus and right atrium. So basically the connection is only to the right side. And again, بدغه حالت کې هم ماشومان incompatible دی life سره یعنی ژوند نشي کولای لیکن په یو شرط هغه compatible ای کله چې دلته again defect پروت دی دلته again دلته یا دلته VSD پروت دی یا دلته atrial septal defect دی چې which will allow the blood to mix. And this was the last slide. This is the last slide, and this basically summarizes the factors that are associated with specific defects. So basically what causes VSD, PDA, ASD, and example, prenatal alcohol exposure results in increases the risk for VSD, ventricular septal defect, patent ductus arteriosus, ASD, atrial septal defect. And this is basically a slide that tasu khpal time ki khpal waqt ke tasu da read kawai shay. So thank you very much. This was all from me, and I hope you guys understood. And tasu tina say tasu poshwe di bande atas tina zdakra okra and the slides chidi